Hello, and good morning, good afternoon, and good evening to all CRSA members, participants, and friends that are attending our worldwide series of webinar. CRSA is committed to the medical education and is organizing every month a webinar focused on hot topics. I think today we have a very interesting topic about liver surgery. And we have the fortune of having with us some of the most expert surgeons and of the world. And I will introduce the panel of the participants, and the meeting will go through some of the assigned topics. I will make a short introduction and I will introduce the panel. And we have with us Yuman Fong, that is chair and professor of Department of Surgery, City of Hope in California. We have Dr. John Martini, that is professor and division chief of hepatobiliary surgery at Carolina Medical Center. Sien Tang, that is chief of hepatobiliary, chief of Department of Surgery in Hong Kong, Pamela Nederson Eastern Hospital. And Pierre Clavien, professor and department head at the University of Zurich, Swiss. And Jacques Marescot, that is a professor and a director and founding president of the Research Institute Against Digestive Cancer, IRCAD. What to say, just to introduce the topic, I will, in a few minutes, I will make a few comments. Let's start from facts. That there is a worldwide a growth and adoption of robotic surgery. And if you're looking at scientific papers and related to the matter of hepatobiliary surgery, you will see that there is a constant growth. Just to mention some of the papers that we selected from the literatures, more and more institutions are dealing with challenges of complex hepatectomies as well. Unfortunately, I think we have to be very honest, and I think during the discussion we will make more comments on that. We have individual experience, institutional experience, but still we are lacking of good scientific works and papers, and there are few comparisons. It seems intuitive to say that minimally invasive surgery is better than open, but should be proved. This is a meta-analysis, but we see the numbers are not yet sufficient number to draw conclusion. But there is, of course, a trend that is showing that with MIS, we have lower morbidity, shorter hospital stay, and but we have some drawbacks like a longer operative time. This is a study that one of the criticisms is the cost of robotics. I don't think today we will focus on that, but even this I think is a myth, because with a better organization we can contain cost, and the outcomes of MIS, reducing the post-operative stay and complications, is compensating the increased cost of the technology. And what about complex? I think during the meeting we will see a different perspective of the problem. robotic surgery applied to complex or to outpatient surgery. But as a matter of fact, we are seeing more and more complexities that are dealt with robotics, including donor hepatectomies, and we are seeing that this is one of, I did the first living donor hepatectomy, but now there are centers in Korea, in Taiwan, and also in Saudi Arabia with Dr. Brering, that are leading the field with tens of living donor hepatectomies with excellent results. So we are dealing with more complex hepatectomy with biliary reconstruction. This is a series from China with almost 50 cases for cholangiocarcinoma intrahepatic with biliary reconstructions. And I think Yuma will speak about that. There is evidence that we can deal with more difficult segments, and a comparison with laparoscopy, that should be the real comparison, because of course, when doing robotics, we are using a minimal invasive environment. So we are including in the benefits of robotic some of the benefits of minimal invasive surgery. And there is a growing evidence that at least with robotics, we can expand the indication and decrease the conversion rate. And there are no difference in oncological outcomes. So I will try to stick in this 5 minutes introduction, and I would like to now introduce the next topic that is Yuman Fong, that is the professor and department chair at City of Hope, that has experience, a huge experience of robotic liver surgery. And there is an interesting perspective that probably he will introduce. Can we move some of this complex surgery into an outpatient environment, and in this way decreasing the cost and in improving outcomes and decreasing cost? Human.
Thank you very much for allowing me to speak on this very distinguished panel this morning. What I'm going to talk about is moving robotic surgery towards outpatient surgery. And that's because, again, if we can actually get people home faster, back to normal life faster, I think we would convince everyone that we're doing the right thing. And the subtitle for this talk today is really More Cures, Less Invasive. So when we talk about any sort of minimal invasive surgery, the main thing we get rid of is the incision, okay? And therefore, really is the incision dominant operations that we actually help with when we go do minimal invasive surgery. If we have something that we do inside that is actually minimal physiologic stress for the patient, but we get rid of the giant incision, we're going to do well for the patients. And I think of this as two separate parts, okay? Yes, we can do major resections, but when we go do that, we should actually do everything to prepare the patient for the recovery. And I'm going to talk a little bit about that. And certainly major resections, I think we do the right preparations, we can move towards outpatient surgery and quick recovery. But mostly I'm going to talk about the small, poorly placed tumor, and why, if we do it robotically and laparoscopically, we're going to be helping the patient. So starting with preparing patients for major liver resections robotically, I think that portal vein embolization is key, okay? If we think we're really going to take out the entire right lobe for good reasons, when we go do a portal vein embolization, we also know that over time, there's a great shrinkage of the liver if we wait long enough. And so this is a paper we published back in 2010 you look at the plane in the middle of the hepatic vein. This is pre-embolization, 1 month, 3 months, 6 months, okay? If you can actually wait long enough, the patient will have a teeny tiny piece of liver that you're taking out that's a right lobe. And we actually trace the entire kinetics of all of that in terms of left liver growth after a right portal vein embolization and right liver shrinkage. So if you take a patient like this, a 42-year-old physician with liver metastases only in the right lobe of the liver, if you can actually make the right lobe shrink so that the left lobe has completely regenerated even before you go to the operating room, this patient is going to leave the hospital very quickly if you go do the right operation and do it well. So this particular patient was in the hospital about 48 hours, okay, and was actually back at work the next week. So again, preparing the major liver resections with techniques such as portal vein embolization, very key. But mostly, I'm now pushing very hard on the small, poorly placed tumors. Those are the ones that laparoscopically we do. It's really difficult to reach. That's in segment 7, 8, 1, and 4A. Requires big incision for open surgery. And recovery really for small tumors in these areas are dominated by fascial and skin incision. So something like this up here in the corner of segment 7, a little lesion deep inside the segment 7 that requires an entire segmentectomy. But a segmentectomy 7 really isn't that much liver, okay? And if you can actually get up there and go do and have visibility, which is what robotics allows us, control, this is us taking, coming through the parenchyma, and there are many tools that we can use, but the stapler also works really, really well. This is, again, coming along the entire plane of the right hepatic vein, and then, again, many sealing devices, and so some of my co-speakers today will talk about a lot of that. But when you can go and reach up there well and get the entire segment 7 off with minimal blood loss and control of all of the vessels, okay, this is a less than 1 hour operation, and this patient is going to go home either the same day or the next day, okay, and totally possible. And again, complete segment 7 in less than an hour. But we also now need to see better. So this is using ICG in order for us to be able to see the lesions better and make sure that we can take out as little liver as possible. This is a segment 7 isolated lesion way in the back. I turn the patient completely left and have the liver falling right. After you inject ICG, the liver turns green, but metastatic colon cancer generally stays black. Therefore, as I come through the parenchyma, if I see green, I have a negative margin. If I see black, I go take more, okay? This allows us to take as little liver as possible, and that's because that's part of recovery is doing a complete resection of tumor while taking out as little as possible. And as you notice, I actually leave everything hanging, okay? And in terms of moving forward. But it's also about combining operations and doing as few operations, get rid of trouble as possible. This is a 62-year-old physician from a different country who was discovered to have a sigmoid lesion, along with a single lesion high up in the chest. He had a very barreled chest that you can see how high his liver is, and his segment 7 lesion is way up there at the top of the liver, and wanted to come to California to have me take out both things at the same time. And again, being able to use the XI robot to be able to go and work on the liver and then work on the sigmoid colon allows us to actually get at all of this. And again, I hang the patient right side up. I leave all the ligaments intact. I don't take down anything until the end, because then again, gravity does traction. The triangular ligament does the counter traction, and then I can actually use all arms for operation. And that fourth arm is not just a static retractor. And again, taking out this liver lesion up there really is pretty straightforward and trivial, and is less than about 40 minutes of worth of work. Once I put in the bag, we can actually proceed to work on the sigmoid colon. And by just turning the robot, that allows us then to save the patient an operation. So the way I look at these is that even if the patient by ERAS pathways for colon stays in the hospital 48 hours, it's still, the liver portion didn't contribute to the hospital stay at all, okay? The other ways to go and try to minimize recovery really is I do three other things. I do extraction and staple ports through the rectus sheath. Therefore, I close the anterior and rectus sheath separately. I don't really care about the size of the skin incision. I care about whether I need to stitch muscle. If I don't stitch muscles, patients recover very quickly, okay? And I use natural orifice extractions, and I use existing incisions. Let me show you what that means. Many times the patients will have potential ovarian metastases or worrisome for ovarian metastases. And if that's true and they need a TAH PSO, and here I am doing a right posterior sector. And therefore, after the posterior sector is done, I put it in a bag. And you can see it's not a small piece of liver. Then we proceed through the vaginal cuff. We leave the balloon up, and we use a vaginal balloon. We keep pneumoperitoneum, and then we could actually extract the specimens through the vagina in a very, very facile way, and therefore the patient wakes up with just 8mm incisions. Okay, when we go do this, closing the vaginal cuff is really not a hard thing, and therefore suddenly there are no muscle stitching incisions to worry about the recovery. I also use, if there's an ileostomy I need to take down as part of my liver resection, I will put a gel port in it and put 2 or 3 ports through it and work through that. This is a colostomy that I put a gel port through and a site that I take down. So again, using old ostomy sites as we go and take them down when we go do metastatic colon cancer saves on a number of different incisions that we might need to do for accessory ports. So these are the last 100 robotic livers that I've done. And again, most patients, 2/3, stay less than 3 days, okay? And in America, if you stay only 1 midnight, it's considered outpatient surgery, and you're really not admitted to the hospital. But it's more than that. It's really recovery. That's because, again, we're not going to go do huge randomized trials of robotic surgery versus other techniques. We're going to go measure true recovery and prove to people that we are actually having recovery. This is that right lobe I showed you earlier, where the patient, who was a physician, was walking 6,000 to 7,000 steps for surgery, dips down for 2-3 days, and it's back to 6,000 to 7,000 steps by day 7. Okay, we could go measure this at home and prove it. Then there's no doubt in people's minds that we're doing the right thing. But we also are measuring all of this because it's important to track these patients now. We're doing major liver surgery and sending people home. We can make sure that they are doing well at home and safe. It'll be very difficult. So again, we are now using patient-reported symptom apps at home. They're reporting to us how they're doing. And this is 2-3 times a day they go on their app and report it to us. We're using FDA-approved sensors that includes blood pressure cuffs, oxygen sensors. There is a whole bunch that are used. We're now using activity sensors to track how fast they move. And now we're also developing novel sensors. So this right here, you see this tiny thing that is about the size of the eye on a Lincoln penny? It's a complete sensor that senses oxygenation and senses pulse rate and senses mobility that we are hoping to implant under the skin of patients and track them. This works on microwatts of energy and can transmit to the cell phone. So along with investigators at Caltech, which is one of our sister institutions, we're now working out the next generation sensors so that we can actually not only do major surgery, send people home, but track to be sure that they're doing their home safely. So again, I think that outpatient liver surgery is here. I think that robotic surgery is here. We just now need new ways of proving to people value, and I think the field is nice and going strong. Thank you very much, Pierre.
Oh, very nice presentation. I'm sure that we will have plenty of questions, and if you have time to make a debate at the end. Of course, the perspective of moving some of these complex operations into an outpatient basis is a very interesting and fascinating one. Of course, there are a lot of issues, including legal issues. If a complication happens and not recognized at home, and we know that by leak bleeding, that might happen even in the first 24, 48 hours. And if the patient is at home, it could be a problem. But let's move ahead. And now I would like to challenge our panel with another provocative presentation. I'm asking Professor John Martini, that is Division Chief of the General and Hepatobiliary Surgery at Carolinas Medical Center, University of Carolina. And the question for him, which are the limits? If really we can do more and more complexities, even think about moving this complexity into an outpatient basis, which are, in your opinion, the true limitation of robotics in liver resection? Please, John.
Thank you guys for the invitation. Pierre, thank you for the invitation and the introduction. I'm actually not the chief of the division. I'm just one of the faculty, believe it or not. So I'll be happy to share with you my thoughts on the limitation. I'm going to share my screen, and hopefully things go through here. And let's make sure this is up and running. Hold on one second. Let's see. Let's share screen, minimize. And so this is a difficult topic. Obviously, I do have some disclosures. I do a fair amount of work with Intuitive and some of the other companies, which I would disclose. I'll talk about the evolution of robotic liver resection, my practice, and the limits, as we talked about, and an important concept called the ceiling effect, and what that means. You go to meetings, and some of the common myths you hear from people who do liver surgery is that, oh, it takes too much time. The robot is simply an expensive tool, so I'm only going to use it for suturing, and it's more expensive. And the most common thing is that I hear from surgeons is they already do most things laparoscopic. This comment of no benefit of a robot for liver resections, I'm already doing them lap or hand assisted. That's something that actually I would say at meetings from about a 6-year period from 2006 to 2012. So you have to first start with the evolution of philosophy. You have to keep an open mind. Don't rely entirely on surgical dogma. So for example, this is how I learned to do liver resections, and you have to be open to change. You have to have some sense of humility. My perceptions of the limits of robotic liver resection early on in my robotic experience, that is prior to 2012, these were my perceptions. And what I mean by that is my thinking when I went into why I wasn't doing robotics was that I needed to have a surgeon at the bedside with a laparoscopic energy device and with endovascular staplers. And so for me, I couldn't rationalize why I would want to do a surgery with a robot. I also thought at the time I was using lots of hand ports. You'll hear surgeons say, well, I have to take out the right lobe, so therefore I need to make an incision that would accommodate that. So what's the point? At the same time, I think everyone felt that difficult hilar dissections needed to be done open. So those were the perceptions. And what I mean was the perceptions is what limited my practice. So when I started robotics in 2006, I was doing most of the liver cases were pure laparoscopic. And it wasn't until about 2012 that I converted from lap to robotics for liver specifically. What that allowed me to do was eliminate the use of endovascular staplers as the primary mode of parenchymal transection, which is the American technique of lap livers, and eliminate the use of additional energy devices such as a ligature or a harmonic scalpel or a CUSA, to name a few. So I essentially eliminated doing liver resections a la staplers. This, what I call evolution of technique, essentially, and I initially adopted the robot specifically to do the hilar dissection. That was something that I just didn't feel comfortable doing laparoscopically, that is dissecting in the hepatoduodenal ligament. At the time, again, my feeling was the weak aspect of, or the limits of robotics was the parenchymal transection. As we didn't, when we first started, we didn't have a device really well to do that. But with time and experience, as I got better and techniques evolved and matured, simultaneously and not unpredictably, you know, the technology got better, meaning we got better tools. So all of a sudden, the robotic vessel sealer came out somewhere between 2013 or 2014. The robotic stapler came out, and then we started getting even more advanced tools like integrated ultrasound and using Firefly with ICG for resections. And as things got, as we got better, as I got better, and the tools got better, even more and more complex cases were attempted. So here's an important concept for probably many of you out there, this concept of a ceiling. What I mean by that is every surgeon, whether they do robotics or they're an open surgeon or they're a lap surgeon, has a ceiling. Within a few years of completion of your training, that you reach a maximum of what you can do technically, whether that's a liver transplant or a portal vein resection or a Whipple. And surgeons get entrenched in their techniques, they get entrenched in their practices, and there is increasing resistance to change. They develop their own dogma. I had reached my limit of what I could do laparoscopically after probably about 4 or 5 years in lap livers, and there was no way I was ever going to do let's say, for example, a right hepatectomy with an extensive hilar dissection. There was no way I could do that. Those were open cases. So I began to change. This is an interesting curve. You see here, my curve is in purple. I'm sorry, my curve is in yellow. Up here, two of my partners who do laparoscopic but non-robotic. The important number on this slide is this surgeon here, who went from doing only about 25% of major liver resections up to over 60% of major liver resections with the use of robotics. So the robot really accelerates the adoption of minimally invasive major liver resections. What I'm going to go through is, this is not a technical talk, so I'll just show you essentially how we do the steps of a liver resection and what I mean by that. So robotic hepatectomy involves this hilar dissection, and I'm going to just skip through some of this. And these are the steps that we would do for a typical robotic right hemihepatectomy, which includes a hilar dissection and individual dissection of the pedicle branches. So here we are dissecting out, this is the right hepatic artery as it emerges from behind the bile duct, just like we would open. And I think to be if you're going to be doing this for the people watching, you have to do ultrasound. So here we are, we're ultrasounding to make sure that we've in fact taken the inflow, arterial inflow to the right, and then we've preserved the medial sector. And then these techniques should look very familiar to people who do open surgery. So it's just good old fashioned silk ligatures, locking plastic clips. There's no, no one's shoving staplers in here. And I apologize for the video is running a little slow. And that's, I'm going to skip over that video because it's not running well. So that's essentially a right hemihepatectomy. The limits of robotic liver resection are due in two things, I would say. Number one is the individual surgeon's skill level and experience on the robot. So if I'm taking someone who's a very beginning robotic liver surgeon, they may not be technically capable of doing a major hepatectomy because they just haven't acquired the skills on the robot. The second thing is what I call the perceptions. That is, the surgeon may feel, oh, well, I don't have tactile feedback, so I need to have my hand in there. Or as you'll hear in one of the next talks is, well, I really need a better tool to go through the liver parenchyma, or I always use a CUSA, or we have two surgeons. So those are the perceptions. That is, the perceptions of the surgeon actually limit their ability to perform a major robotic liver resection. And so surpassing these resections, once a surgeon becomes technically able to do major liver resections and then non-anatomic liver resections, that is parenchymal transections, you can really move on to the more advanced cases. So that the limit is a moving target. The things that we do now, which I would have never considered doing, 5-10 years ago, are things like ALPS procedures, staged liver resections, hepatectomies combined with portal vein thrombectomies, and Klatskin tumor resections, that is combined biliary resections and reconstructions. If this runs, maybe or not. This is a video of doing a right posterior sector, or a 5-6-7 with a resection of a portal vein thrombus. I actually presented this in Paris in 2017 at the ILLS, and I can tell you, the first time I considered doing this, I was certainly ready to convert to open, because this is a case that I would have told everyone, this is not a case for a robotics procedure. But you can see here, we're using bulldog clamps to get inflow control to the portal vein. Here is the tumor thrombus that's extending into the right posterior sector portal vein. This is expressing the tumor. You can see there's really no true luminal wall invasion on this tumor. That is, it slides right out of the portal vein confluence. So this can be safely cut out, and the portal vein venotomy is now closed with a running monofilament suture. So that when someone says to me the limits, this is a case that I would have never dreamed to do laparoscopically. There's just no way that I would have felt technically good enough or skilled enough to do. And with the robot, this becomes a task that anybody who does an open, let's say an open liver transplant surgeon, an open hepatobiliary surgeon, if you do it in your open practice, you can certainly do it with the robot here. It's actually a better optical picture. There's no tremor, there's no shaking, and this can be done safely. So that's certainly something that I think you can master, and you can see here. And things like cholangiocarcinomas. I don't have time to go through this whole video, but suffice it to say, this is doing an extended left hemihepatectomy with resection of the bile duct with a Roux-en-Y to not just the right ducts, but this is suturing to the right secondary radicals, that is the right anterior sector and posterior sector bile duct. Suffice it to say, there's no way I would ever consider doing this laparoscopically. I'm just not that good. In fact, this is a difficult case to do open. But these are the kind of cases that one can achieve with time and practice. That's not to say, and I'm gonna, in the sake of time, because I want to stick to my 10 minutes, you don't start out with those cases. So in summary, the limits of liver resection, robotic liver resection, really due to the individual surgeon skill sets and their perceptions of what the limits of the system are. I'll guarantee you that what I have just shown you, many people would say, "Oh, you can't do minimally invasive liver resection. That has to be an open case." That's just not true. The tools are there once you develop the skills. So the limitations are not due to the lack of any robotic instruments we may or may not have, specifically parenchymal energy device. We have all the tools we need. We just need to get there. And I think robotics may enable even expert surgeons to surpass their own limitations, what I call the ceiling. And with that, I'll stop and move on to the next speaker. I'll stop share and hopefully.
Okay, thank you, John. Thank you.
I would think that was right on 10 minutes.
Nice presentation, and thank you also for respecting me. I think we will have the chance of going back to the topic of limitation, because I think this is a key point to understand also the future perspective of robotics. Only understanding limitation, I think we can move forward.
Yeah.
Now, I would like to introduce the next speaker, that Xian Tang, Chief of Hepatobiliary and Department Head at the Pamela Hugh Netterson Hospital in Hong Kong, and that is a famous HPB, minimal invasive surgeon. And so Xian, good evening for you, and thank you for accepting to participate even during the night for Hong Kong. So the topic for you is another interesting topic that, of course, it could be connected with the limitation. Do we have the right tools to do a complex liver resection?
Thank you very much, Pierre, for your kind introduction. Let me share my screen first. Something wrong with sharing. My screen, sorry. I can't share my screen. I'm so sorry. I got a bit of trouble. At once.
Okay, Dr. Tang.
Yes.
You have the green button on Zoom.
Yeah, I put it on, but I cannot see my desktop. Desktop.
Yeah. Okay, perfect.
Desktop. Can you see it?
Yes.
Can you all see it?
Perfect. Thank you.
Oh, perfect. Okay. My talk is what will be simple. QC harmonic. Do you have the right tool for robotic hepatectomy? And this is a French comic drawing, and date back to about a century ago, and telling you what we expect to see the operating theater in the year 2000. And the thing about there are many similarities. What we are doing right now, we are not standing next to the patient. We're basically controlling and doing surgery with our fingers, and also stepping on foot pedals, and also working at the distance, rely on all these pulley systems to do surgery. So technology is so important for surgical development, but never forget about power of imagination, which basically can take you everywhere. The Da Vinci robotic system was introduced at the turn of millennium, but at the end, a child is still a child, and robot won't make you smarter. And think about how you build the foundation of knowledge and skill, and also the principle of surgery, and applies the robotic system to do a better operation for your patients. Robotic liver resections, and I believe it is not a heroic of surgery. A surgeon sitting at the console and can do everything. I entirely believe this is a team approach. We have to work with the surgeon at the bedside, and show that work in collaborations, and ensure the surgery can be safely performed. And there are a number of tips and tricks. I will not go into details. It's just largely the same as laparoscopy, caudal cranial approach. And once again, we work as a team. And we have to use all the robotic arms. What seems to be very important for robotic surgery is the axis of operations. I think the axis of operation would be the axis of parenchymal recession, where you put your camera pod. And that can be slightly adjusted with the retraction arm and also positioning, so much so that you can obtain the optimal exposure of the transaction pain for hepatectomy. And once again, all these diagnostic tools are very important. Lab ultrasound for preliminary assessment, robotic ultrasound, once again, very good to assess margin, and also whether you're going to the correct surgical pain. ICG, once again, would be pretty standard right now in this couple of years. I have to emphasize the low CVP, low airway pressure, and also high limbal peritoneum. I usually apply intermittent pingo and working together. And my practice in old day would be left hand bipolar forceps, right hand would be monopolar scissor. I move a little bit from using Cusa and by the bedside surgeon. Now I'm using most of my surgery with harmonic scalpel. So I would touch a bit more about how to compare the Cusa by bedside surgeon versus harmonic scalpel by conscious surgeon. Rhythm of surgery is important, and it's a bit different from what you use or what you do in conventional surgery, because there's still a little change of equipment from time to time, and like passing the needle driver and also the hemolog. And so it would be quite difficult to maintain the rhythm as what we expect in open surgery as on as laparoscopic operations. And this is a consensus meeting on laparoscopic resection date back to 2014. And there are many achievements in that consensus meeting. What seems to be important and would be mentioning some bit on robotic liver surgery. I think this is still quite early phase of development. And there's also remarks about robotic liver surgery, and the type of instrumentation is much smaller than laparoscopy and also open technique. And those are some of the instruments what we can use for robotic hepatectomy, hand crushing, harmonic scalpel, vessel sealing, suction, clips, hemolog, and so on. So I think this is a diagram I like it so much. And think about the superficial layer. You can use all kinds of equipment like a microwave, monopolar diaphragm, harmonic scalpel. When you touch further down, you have to really safe to identify all the BV and also vascular tributary, and also control them one by one with stapler, with dissection and key all this anatomy before you control it. And finger fracture, cam crushing, even though it is a bit elementary, but this is still a very effective tool in open surgery as well as robotic surgery. I would tell you a bit later on how I use the cam crushing technique in parenchymal transections. And those are common tools, what we can use in robotic surgery, ultrasonic scalpel, Cusa. But Cusa has to be used by bedside surgeon because there's no robotic Cusa. And once again, handling technique would be pretty commonly employed to expose the vasculature. Endostapler, when you dissect it down and save a bit of time yourself, control it for big vasculature, people usually use endostapler to control it. And there are different ways of using endostapler. You can include the liver parenchyma, but this is not my recommended way. I think we need dissection to identify the vasculature and deal with the vasculature with endostapler. And this is my belief. And once again, with 8mm vascular endostapler, which can be more precise because exposure is also very commonly limited in robotic surgery. And those are less commonly instruments like tissue link, water jet, RFA, and end-seal, vessel sealer. But of course, there are a diverse type of equipment what you can use in open surgery, lab surgery, and you can also use the lab equipment in robotic hepatectomy. And we come across a lot of primary hepatoma in Hong Kong, in Southeast Asia, because of the prevalency of Hep B infection. So we believe anatomical recession along the portal tributary would be the gold standard for primary hepatoma. Once again, the study from Tokyo University demonstrate anatomical recession and achieve a better survival compared to non-anatomical recession in primary hepatoma. So those are the QNAT and telling you all the anatomy. So the dissection largely along the intersegmental wing. And let me just show you the video and telling you what we are doing. And this is live surgery date back to about 5-6 years ago, lab ultrasound, and identify all the info structures and then control them one by one, including artery, vein on design. And I just want to show you, this is the way how we are doing. I use the left hand would be the penetrated forceps, bipolar forceps, right hand would be shear. The Cusa will be used by the bedside surgeon. This is the way how I perform surgery date back to about 6-7 years ago. And in this case, and you can tell quite well, and this is the middle hepatic ring. We dissect along middle hepatic ring and then all the way. You can see the collapsing middle hepatic ring. And both surgeons work together so that you can speed up the surgery a bit faster. And if you control every single step by yourself, and probably you might have to do it a bit slower. And this is the way how we apply the suturing for the hole in the middle hepatic ring. And last step would be the endostaper. And this is the endostaper, control the rest of the parenchyma. And look at now how I perform the surgery with harmonic scalpel. The initial step would be more or less the same. The highlight dissection, control all the tributary. I will not trying to bore you with all this. Let me just show you how I perform it with harmonic scalpel. And see the demarcation and then mark the line and then control them, ICG. And this is how I use the harmonic scalpel to do transition line right now. And this is the middle hepatic ring. I use it, a very gentle dissection. Left hand, once again, would be fenestrated bipolar. Right hand would be harmonic scalpel. A very gentle dissection, dissect along the middle hepatic ring for anatomical recession, and then deal with them one by one. Right hand here, I think this is another demonstration how I use the harmonic scalpel. More or less the same. The highlight dissection, mobilization, and then go for parenchymal transition, mark the line, and then harmonic scalpel on the right hand. I think the axis of transition has to be very carefully calculated, and so that that can be used without angulation because there's no angle width function for harmonic scalpel. Let me just show you, and this is the middle hepatic ring. So for every single anatomical recession, the exposure of intersegmental ring would be pretty crucial and tell you this is the demarcation between the segment. And this is how we're doing surgery right now. And this is the middle hepatic ring. Look at this. Collapsing because of low CVP, low airway pressure, and also high pneumoperitoneum. Even a tiny hole in the middle hepatic ring will not end with big trouble because you can easily see what with bipolar system. And last step, the right hepatic ring, and you just control it with the robotic stapler. Let me just finish this with the post-incision anatomy. I think this is a pretty good one. And telling you once again the use of harmonic scalpel, how we are doing the surgery. And demarcation, and patient is in a semi-left lateral position, and with ultrasound showing you the location of the right hepatic ring. And once again, when you transet it, and then you start to see the right hepatic ring, and this is the right hepatic ring, you see the branches coming off from the segment 5 and also coming off from the segment 4. And this is how we're doing. So there are different ways. You can activate the cursor and keep it open and break down the different parenchyma when using harmonic scalpel. Or the other way would be cam crushing. Even there's a tiny hole in the hepatic ring, you can deal with it very easily with the bipolar diaphragm on the fenestrated fossa. And this is how I'm doing surgery right now. I think I won't bore you with all this casting tumor and also the using harmonic scalpel. And this is the one with ICG. Once again, this is not my talk. And I just want to show you, this is another way how we can do the dissection. Instead of antegrade, I change a little bit, doing retrograde, and this is segment 8 dissection. So I identify the middle hepatic ring and then dissect from above down to isolate the middle hepatic ring. I was trying to show you this, and this is the middle hepatic ring, and this is the medial margin for the segment 8. And then similarly, I will dissect along the right hepatic ring where it comes off from the IVC, and show that to completely excise the whole segment 8. Okay. So a bit demanding because when you talk about anatomical recession, but this is a very useful tool, and when you use harmonic scalpel. I think QSA by the bedside surgeon, a very high demand for bedside surgeon to know very well they set and the top moving or transition. And usually this is along the intersegmental ring. The console surgeon, in this case, usually will be holding the bipolar scissor on the left hand and also exposure of the transition looping to allow the bedside surgeon to dissect with the QSA. The port of the QSA has to be away from other robotic choker to avoid injury of the patient and also to avoid injury of the bedside surgeon. So the handpiece has to be a bit longer. So the usual handpiece for QSA is very short. We have to use another alternative, which we call sono pad, serving you a very long handpiece to use, exactly the same as ultrasound dissector like QSA. The surgery time could be a bit longer when you're thinking about one surgeon, but you are working together and two surgeons in cooperation. I think the operating time is not particularly prolonged with that. Harmonic scalpel, the axis of transition is very important. That has to be well calculated, and because there's no endo dysfunction, the close and open action of the jaw will be similar to what we are doing cam crushing technique. Another one, you can keep it open and activate harmonic scalpel and break down the parenchyma and so that to expose the hepatic ring. I think the current limitation for robotic hepatectomy, the machine is bulky, but this is improved dexterity, so that you can do surgery in a higher level of precision. You can't very much of the access of camera, so that this is not entirely suitable for multi-quadrant surgery, even it is slightly improved with the X9 model. It would be a bit difficult for a surgeon to switch from open surgery to lap surgery and robotic surgery. I think they can easily think about with the robotic assistant, they can directly switch from open and robotic. And talking about instrument, both ultrasound, QSA, and also harmonic scalpel are very useful, but we need diversification of instruments so that to suit the need of different surgeons. And once again, in order to ensure good outcome of your surgery, you need standardization of procedure. So it sounds a bit controversial, but we need diversity and also standardization at the same time. Instrument has to be diversified, but procedural step has to be standardized. Conclusion, QSA and harmonic scalpel are commonly used in robotic hepatectomy. And to my understanding, to my personal experience, both are equally effective. What seems to be limiting would be the surgeon experience. How can they use it appropriately for different settings? And we need more diversified instrumentations and to remove obstacle of learning robotic hepatectomy. Robotic hepatectomy will prevail and become prosperous with improved technology and instrumentation. It will be a bit difficult to surpass laparoscopic hepatectomy if the price is persistently high, unless it becomes more affordable in future. I think that's the end of my presentation. Thank you very much for your attention.
Asian, congratulations, very nice presentation. And what to say, definitely, I'm happy that after years of debate and controversial arguments about the best tool, finally, we came to the same conclusion that harmonic probably is the most acceptable. But I think we will talk a little bit more before the end about how we can overcome limitations of tools available for liver surgery. Now, I would like to introduce it doesn't need introduction, to be honest, because it's one of the most famous surgeons around the world, Professor Pierre Clavien. And that is a professor and department head of the Department of Surgery and Transplantation, University of Zurich. I think his presentation to me is particularly interesting because he is a strong liver surgeon that is able to do the most challenging open procedures and minimally invasive procedure as well in his institute. So I would like to understand his opinion about the role of minimally invasive surgery in liver surgery. When do you think that minimally invasive surgery is better than open surgery, and when still we have to consider open surgery the standard of our practice? Pierre.
Yeah, Pierre, thank you very much for the invitation. As you mentioned, I mean, I don't consider myself as a robotic or even minimally invasive surgeon. Was involved in liver transplant and sort of major surgery. And as John Martini mentioned before, I think I also had my ceiling and thought, well, for a long time, we can do it open and this is major surgery and the patient doesn't care about small incision, etc. You want to survive, etc., etc. So that's most in this category. We even did some papers a decade ago to suggesting that robotic will be one day something, but at this point was not. And with the XI, about for 2 or 3 years, we did change my mind. We could really see that in some situation it was better. So today my talk is not to impress anybody and to show that we are robotic and do, but maybe to show for us what has become now routine in our practice in terms of doing robotic surgery. So I think it was already said before, but I think I can just reinforce that. For us, clearly, when we have lesions that are difficult to access, if you do open surgeries, major mobilization of the liver, etc., laparoscopically is very difficult. We also went a little bit to the laparoscopic world. We were really open, and now I think we will go. I'm one of those who may say that you should go to the robotic with some experience in laparoscopic, but I do believe that the experience in open surgery, and they've done many things, is maybe even more helpful. So I just here show a few cases to illustrate that, and I think at the end maybe a discussion. So we have a patient like this one who come to us, a small liver met, recurrent liver met. We know that laparoscopically, at least I cannot do it and will not do it. And open surgery, of course, we can take it out, but that would be a major mobilization. We have to do a pretty large incision here. And in addition, we have patients in this country, like you have in the US and others, with problems here. This was 74, metabolic syndrome. He had an ileum conduit, COPD, etc. So really, I think this is for me one example where clearly robotic surgery is superior. You can see here that we learn also here to place the trocar to do this. And I show you here short video because again, I don't want to show any much technique here. So the patient is on the lateral side. We also do the flyer. We gave ICG green. Here it was not positive, but sometimes it's very nice to see it when it doesn't matter. You can see the small tumor here, very posterior here. I will not comment about the technique. Here we use the harmonic scalpel in this situation. We also do an ultrasound that I don't show in this video. And here with a pretty minimal invasive, we don't use very often the radio frequency at the end. In this situation we did. That was one of the first to extend the chance that we have a negative margin. And if we go here, if I can go here, oops, no, that's not what I want to show, I'm sorry. That's the patient, you can see this patient, and even us were immediately convinced that this is a good way to go in this kind of patient in we're home here at postoperative day 3. And I think don't need a randomized control trial here to know that with open surgery, you will never achieve this kind of result as an example here. Here, this is another one indication that one, again, another small tumor here, segment 8 of the liver. I just show you here a bit what you have shown. So we have this lesion, we can see it on the surface. We'll do an ultrasound to really mark as it is. And here in a relatively simple way, and if we do the open surgery, we will do basically the same. We will go around and we will remove this lesion again here. With what I do often here is, that's also what I do the open, try not to see the tumor, but we put here a stitch which enable to lift up this, since we don't have, in my opinion, all the instrument I would love to have here, so we can lift up that. And here again, with the harmonic scalpel, we can go around that and we will take the piece, we'll put some ink around to make sure that we have a negative margin. So nothing different that we will do in the open. It's much different for the patient because he has really not basically no large incision. You can take this tumor here through a trocar, and of course that will ease up the recovery in this patient. We'll go here. Okay, the bike, there's not much to show here. Try to go down here. That's another thing I wanted to show, because now we use the robot relatively often for this. And this is the Echinococcus alveolaris. We have, that's the lesion here, you can see it. It's a lesion here anterior in segment 4A. In the liver here, you can see it goes not too deep, but relatively close to other things. I will not do a classes on Echinococcus, but we have this mainly in Switzerland. It's increasing. This is go to the fox, and we see fox in our city now. If you go late at night, and they are not, there's a lot, but they try to eradicate, but we see a fair number. And in fact, you can see 97, that was the area in Europe when it was alveolaris, and now it extends in many other countries. And this can be one of the most difficult hepatic surgery, and I often compare that to cholangiocarcinoma because this tumor infiltrates a lot. I just show you here one of the video, one we did recently, a couple of weeks ago here, in one, the patient that I just showed before here, and we used a pretty simple technique that we have here anteriorly. So here, that could also be done laparoscopically, but I think it's better with the robot here, with more flexibility with the instrument, and we guide with the ultrasound because there is ramification of this tumor in the parenchyma to take that out. That's the ultrasound that we use during this surgery. And here we also, we use the same technique that we use in the open here. I put some stitches to have a perfect or a good retraction when we go for that. So that's when I see my own experience that the robot is pretty wonderful, because that's the Pringle that we did here in this anatomic. We don't do it routinely, but that's a simple way of doing a Pringle in this situation to remove this with a low CVP, as was mentioned. Open surgery is the same. We have in the advantage here, or we increase sometimes a little bit the intra-abdominal pressure to 15. I know there is the risk of air emboli, but I think sometimes it's very useful, and we basically have the scenario of total vascular exclusion, which make the resection pretty safe with minimal bleeding in this scenario. We go here down, here, no, sorry, here. That's the incision, so nothing special in this case, and that's the piece that we have at the end of this Echinococcus alveolaris. Another thing that we are doing here, there's few centers who do that, but we put a pump for intraarterial chemotherapy, and we have done that open usually, sometimes laparoscopically, and now we do that. We've done about 15, and we do that now only with the robot unless there's been extensive surgery before. And the main indication for us is intrahepatic cholangiocarcinoma. You can see here pretty large intrahepatic cholangiocarcinoma here, and we start with chemotherapy, and now we have some data that we reported that we have very, very nice down staging with intraarterial chemotherapy. We use FUDR. Credit go to Memorial Sloan Kettering, who treated that Nancy Kemeny colorectal tumors, and here we convert this to a fair number to resection, and we even done a few transplants in patients that clearly were not candidates for transplant initially with this kind of disease. So I just want to show you a short video of this, what we do here. So that's, I mean, the anterior that we can see here, we can hear the parenchyma, the stomach that is here. And here I go further, I hope the video works. So here, this is a relatively easy approach to the hepatic artery here, the proper hepatic artery, we know where that is. And what we look for is the gastroduodenal artery. So we do this dissection here. We have the artery in front of us here, as you can see here. So how we go around here of this hepatic artery, we look for the gastroduodenal artery. We need the ligate, also the right gastric here. So we know that's here the gastroduodenal artery, the one we dissect for 2 or 3 centimeters, exactly as we do for open surgery. I mean, there's really no difference. And we have the same criteria for this. Then we isolate, we clamp, we clip here, and then we go around the gastroduodenal artery in this situation. We put the clamp here. So it's done here with absolutely no bleeding so far. We prepare, we introduce the catheter here for the selective intraarterial chemotherapy that we can fix. And when I started to go with the robot, I love it because with the camera, we can be 1 millimeter very close, which what loop or whatever you cannot. We do the fluorescein test to make sure it goes on both sides of the liver. And at the end, we have this with the pump, which is placed subcutaneously in these cases. I'll go to the last slide here. So I come to the end. I think I don't have much more to show, as I say. in terms of robotic. So what are the indications in our practice? I think has been said clearly for the segment that are difficult access who will need a big incision. There is absolutely no doubt that the robot here offers all the flexibility to do good surgery, safe surgery, and have good oncological, respecting the oncological, so there's no anatomic resection. And we reduce the surgical burden. That's the example of the pump here, the stage 1 of ALPS. We've done a few also here. We want to reduce the inflammation and whatever is associated with that. So we can, with the robot, ligate the right portal vein and do a partial transection. We have not done stage 2 yet. Others with more experience in robotic have done complete ALPS procedure with this, but I think this is certainly an advantage of that. So I just finish my talk here. And again, thank you so much for inviting a non-robotic surgeon to this meeting.
Thank you, Pierre. And I really appreciate your presentation. And I think it's very, to me, it's very interesting because you, as a very good comprehensive liver surgeon doing a complex open surgery, you start admitting that in some indications where laparoscopy is probably challenging, like difficult posterior segments, or when you have to do micro dissection, like the vascular micro dissection required for a placement of a chemotherapy pump, robotics probably has a clear indication that you can do minimal invasive. But I think I'm starting from your comments that I would like to share with you before the last and the best presentation of Professor Marisco. And I would like to share my vision about liver robotic surgery. You see the picture here of the new training lab that we recently opened at University of Illinois in Chicago. And really, it's not that big like the IRCAD, but I think it's very sophisticated with artificial intelligence, robotics, and a lot of 3D simulation, reconstructions. And we will discuss probably a little bit more at the end that. This is my disclosure. And what to say? I think I admitted that this vision, starting with this statement, seems very provocative. I would like to say all liver surgery one day will be done robotically. And it's a very strong statement. And it was a dream of mine since I got started. And I admit that it's a biased vision. And why is biased? It's biased because I had the fortune of starting so early with robotics 20 years ago, and I contributed to develop the first complex procedure. And you see the list here of some of the procedure that started in Italy, a lot of worldwide first, and through the years, continuing in Chicago, I kept working on limitations and pushing forward the indications, including transplants. And this is my personal experience. There are majority are big cases in complex procedure, but more than 80% of my surgery is robotics. And this to tell that, of course, as clearly was already well said by John Martini, that of course the personal experience, it matters a lot. So my personal experience with robotics is able to compensate the limitation of the system and the platform. So this is my experience focus on liver resection, but we can see what is impressive here, that even with very complex operations and intrahepatic reconstructions and difficult segments, mortality is 0. Of course, a well-organized intensive care and post-op, I cannot dismiss the importance of having a good comprehensive team working on HPB. But if you see conversion rate and transfusions, they compare very, very favorably with laparoscopy. So I think there are several aspects of robotic surgery that we cannot dismiss, that the ability of microsuturing in a complex field where laparoscopy is failing. And I think probably this is one of the most interesting. For anatomical liver resection, there are steps that are clearly superior. The way you can microdissect a difficult clasp in the hilum of the liver with the robot is not the same. I have to say even better than open surgery, because you have the combination of stability of the platform plus the magnification and the end of wrist. The combination of these three, it gives you microscopic surgery inside the human body. For sure, we can do more and more complex, but individual skills, including open surgery experience, are compensating the limitation. So let me discuss a little bit more about the limitation. If it's true that individual skills can compensate, but still there are limitations, only in a very humble way and honest way, we are starting from the limitation, we can move forward and to achieve the goal that I think it should be an achievable goal, and that one day we'll be doing a super selective robotic liver surgery and discharging patient back home in few hours, as a human told us at the very beginning. So let's review some of the limitations that in my experience are the most important. There is a need of specific training of the team. It cannot be dismissed. Probably we don't need a second surgeon, but a specialized training, yes. If you are in a trouble with a bleeding and you have someone that doesn't know how to make suction and is going around with the suction device where you are, it's a mess. You are unable and you need to convert. So there is a requirement of a skilled assistant. It doesn't matter if it's a PA or a fellow, but has to be a skilled assistant. The system is rigid because this is the concept of the platform. And this rigidity in some situations is an advantage because you have a stability of the instrument, a stability of the vision, of the scope, but at the same time, you cannot compensate. So you cannot change the direction of the angles of the trockers. You have a limited working space. And so the rigidity of the system becomes, in some situations, a limitation. There is a lack of proper instrument for parenchymal transaction. I disagree with John that still we need better tools. And the fact that the companies that they didn't deliver the right, because there was a small group of hepatobiliary surgeons doing robotic surgery, but now that we have a perspective of a bigger market, I think the company should focus on giving us better tools. And speaking about tools, there is one that indeed it is asking about scissors and the hook. Of course, it depends the dissection. If you're going around small branches or more small vessels, the hook is much better because it is an end of wrist at the right angle. And if you have to divide fibrotic tissue or go through some structure with stronger texture, probably the scissors are better. So I think you have to be proficient with both and knowing the way your instruments are working. There is a lack of dedicated staplers. When I'm saying dedicated stapler, it doesn't mean robotic stapler. We have robotic stapler now, but in my opinion, that are not perfectly adequate for the liver parenchyma. They are perfect for colorectal. They are perfect for the lung, for some vessels, but I don't think they are the ideal stapler for for example, the flexibility of the tip is too much for in some situation when you have to go through some cirrhotic liver, for example. That's it's and there are other features and the size, of the jaws, and that we should have dedicated liver stapling devices. And emergency situation, they may require specific protocols. It can be improvised. We at the University of Illinois developed some algorithm and some protocols, and who is calling the emergency, could be the anesthesia or the surgeons. Everybody should know what to do. Large maneuvers are not feasible. Of course, with your hand, you can compensate. And if you have a tear on the vena cava and you can put your hand inside, you can compress, you can speed up the resection, and you can retract. You know, our hands are multitask perfect tools. And there is a space enough to do maneuvers like a tilting of the liver. I think these large maneuvers are unfeasible. Clamping of vessels, again, we don't have the perfect clamp. Bulldog, yes, we have bulldogs and we are doing a kidney transplant with that. But are you at the moment thinking that you could do a liver transplant? Do we have a Satinsky that we can clamp the hepatic vein or the vena cava? Or we can imagine to have a different kind of clamp that can be assembled inside the human body. That's in diagnostic tools. I disagree with surgeons saying that we have the perfect images with the ultrasound in the robotic liver surgery. There are a lot of artifacts. And tactile feedback probably is not a priority, but we should find a way of replacing tactile feedback with better senses. Tactile feedback is a way to compensate, for example, the poor understanding of a tumor margin, but is a poor compensation. And so we should develop better images and better diagnostic tools, and in this way. I think I will speed up some of this because I'm sure that Jacques will touch more about this. But I think that for sure we need to work in that direction. Better images that are improving the intraoperative evaluation. There are future direction that we can consider for liver transactions and a new generation of images, and we will be able to take advantage of the real concept that is behind the robotic revolution, to be able to perform a digital surgery completely. Imagine to have a situation where you're doing surgery, you are constantly able to visualize the presence of the tumor and its margins. The robotic station is already prepared, is the best platform to integrate artificial intelligence and 3D reconstruction modalities all the benefits of artificial intelligence with a microsurgical platform with the best mechanical features. So I don't want to spend time on that because Jacques Marespo will speak about the images. All liver surgery will be done robotically. This is the provocative statement at the beginning of my speech, and I think it's an achievable goal. But we need to work all together as an international community, and I'm happy that the Surgical Robotic Association is helping in keeping together all surgeons through these difficult times of COVID, and helping in restoring what is science requires, in continued exchange of opinions and feedback and idea for the best development of science. We needed to develop a multicentric studies to validate scientifically what at the moment is only individual report of experiences. Better standardization of procedures, development of protocols and guidelines, and developing true partnership that are going beyond the single individual that is helping in training, but through partnership with companies to develop better specialized platform tools and images specifically for liver surgery. And at this point, I would like to ask Professor Maresco. Jacques is a friend, and it doesn't require any introduction. Is a living legend of surgery and director of the IRCAD in France and founder of the IRCAD. So I would like to know from Jacques, there are any updates, which is the point of the virtual imaging reconstruction that we could use for liver surgery?
Thank you very much, Pierre. But I think it was in some of your videos, we have seen also the importance of virtual reality and augmented reality. What I want to explain is that since more than 20 years in IRCAD, we work on the concept of augmented surgery. And in augmented surgery, I think the most important thing is a vision. That means how we can improve the vision of the surgeon. And you know, this vision, this virtual reality, augmented vision is integrated in the robotic system. And today, due to the explosion of artificial intelligence, we have absolutely a support to reconstruct very quickly and to support the surgeon during the operation by the strength of the image. So if I want, first of all, to explain the 3D reconstruction very quickly, and that is an example of the importance of the 3D image. In all our courses of advanced hepatobiliary surgery, we show this case of a cholangiocarcinoma. We all know that it is sometimes very difficult to know where is exactly the cholangiocarcinoma. And here, for example, I know that radiologists, the surgeon team were absolutely convinced it was on the right side. And you are going to see when we have the 3D reconstruction, it's very easy because we can remove what we want. And when we have just vascularization, you see that in 1 second, everybody can share the image and see that the tumor, the cholangiocarcinoma, is not on the right side, but on the left side. And when we can use on the image what we call a virtual clip, we know exactly what is removal of the liver that we have to plan. I have another example for pediatric surgeon because it is a good example. You see this huge hamartoma of the liver on a young baby of 2 months old. And you see how difficult it was for the surgeons to know how to start the operation. And with this kind of software, we can navigate inside the tumor. And you are going to see immediately that we see the two arteries going for the vascularization of the tumor from the hepatic artery. And so it was very easy to control immediately these two arteries. Another application is also the preoperative simulation. We know how it is important to do that before the operation. 3 metastases of the liver. We know that for the two on the left side, we propose a 3-segmentectomy. For the other one, we want to have a radiofrequency ablation or cryoablation. And you see that with the software, it's easy today to know the best trajectory we have to put the needle, exactly in the center of the tumor. And more, we have a realistic reconstruction of the effect of the virtual burning of the radiofrequency. And you see also that we can put all the instruments we want on these what we call personalized simulators. And we have the optic, and you see that when we introduce the optic inside the abdomen, we see exactly what we are going to see the day after during the operation, but with the possibility of transparency. And now, after the 3D reconstruction, after the simulation, what we want is a fusion. And that is exactly what Pierre Giulianotti explained. The strength of the image is to have a possibility of fusion. If we have the possibility of fusion, we can see in transparency during all the operation. And we know that that has to be integrated in the robot. That means the augmented hand has to be augmented vision has to be integrated in the augmented hand. Just an example, it's not a complex surgery. We don't need the robot for this surgery, but just to show how it works. We have a tumor, we can do a preparation of the tumor. We know exactly the resected volume that we are going to remove. We can, in the operating room, simulate the exact positioning of the trocar before we do the setting of the robot. And when the robot is in place with the different arms, we can see that when we are immersed in the master part of the robot, we can see the normal image, but also the virtual image, and we have the fusion of both. So that is very nice. That is very nice, but it is absolutely more complex. It is more complex because we have a limiting factor today. The limiting factor is what we call the rigid deformation given by the computer. And we know that the real life surgery is not a rigid deformation. It is a non-rigid deformation. I have a lot of challenge to overcome with the team of researchers. The first problem is that when we do the image, you know that before the 3D reconstruction, we need the medical image. And we make this medical image in a CT scan, and it is nearly always done in a supine position. But during the operation, you see that we can have a lateral decubitus, we can have a prone decubitus in surgery. So the machine has to understand the new position of the patient in the operating room. And you see the researchers, they have really overcome this first challenge because with a very cheap RBGD camera, you see that they have what we call an external mold of the patient. And if we have an external mold of the patient, you will see that we have the preoperative 3D modeling. And during the operation, you will see that we have a perfect superimposition of what we call the soft tissue. That means the muscle, that means the skin. So that is the first step. But when you look at the video, and that was the same when I have seen the video of Pierre Giulianotti, we see that we have not the exact superimposition for the organ because nothing is exactly superimposed. And we know that that is difficult for a lot of reasons. The first one is that we know that we have a modification of the position of the liver due to the bracing. Here is a dynamic MRI. We know also that, and that has been overcome. That has been overcome like that because with some external markers on the sternum, you see that the researchers, they have developed some predictive algorithm and we can calculate the new position of the organ. So you imagine that is a very important step which has been done. But we all know, and that was also on your video, Pierre, that the first thing we do with a robot or with laparoscopic surgery is just to retract or to grasp the lever, and immediately we have a modification of the volume and modification of the position. We need to take in account the virtual elasticity of the lever, and that is very, very difficult. And I know that today no team in the world have solved this problem. We tried to move on, and that was the reason why we have created, just in front of IRCAD, a new building totally dedicated to image-guided surgery. And that was a big, strong partnership with Siemens in the operating room, experimental OP room, but also OP room for patients. You see that we have all the machine. We have the CT scan, we have the MRI, we have a robotized CT scan, which is a Zygo first. Now it is the Pheno. We have also the 4D ultrasonography. And so the building was done, and it works like that. That means for a complex hepatic surgery, we can have in the operating room the CT scan. That is very important for the fusion because we know that the volume of the liver in 10 days can totally change. We have the arterial phase, the venous phase. Because we want the exact anatomy of the biliary tract, we can have the biliary tract given by the MRI in the operating room. And you see that during the operation, the Zygo or the Pheno can give an image. And that is very interesting because we have low irradiation, so we have not a very, very good image, but this machine is so smart, she can take in real time the data of the CT scan, the MRI that you have done in the operating room, and you can have a superimposition. Finally, augmented brain for the image. It is very important because we need to improve the diagnosis. We need to improve the image during the operating room. And I just want to give one example, which is the Condor project. The Condor project is how we can imagine to have like a control tower in the operating room. And that was started 2 years ago with a different French company. And you see that it is possible to analyze in real time the preoperative, the intraoperative, the 2D and the 3D image, the external camera during the operations, the laparoscopic camera, but also all the physiological signals given by the anesthesiologist. And all that is as a storage, and with artificial intelligence, we can, after that, follow the patient until he returns to work to analyze exactly the result of the operation and to teach the machine. That is the definition of the deep learning. And finally, to explain how artificial intelligence is important, you know that to give all this 3D image, we have elaborated a spin-off of IRCAD, which is Visible Patient. And you see this kind of reconstruction. It is a service which is given by the company, but it was long. It was between 2 and 3 hours to reconstruct exactly the liver. And now with artificial intelligence, it is less than 10 seconds. So you imagine, and that was a progress in the last year. And today we are very happy because, it is very important to go from dream to reality. And we signed an exclusive license to Johnson & Johnson for this project. And really, I hope that majority of patients can benefit of this 3D reconstruction. Thank you very much for your attention. Thank you, Pierre. I think it was, for me, very interesting, all the topics that I heard since the beginning of this webinar. And congratulations to have organizing this webinar in this chaotic viral period. Thank you very much.
Thank you, Jacques. I think I was right saying that we are reserving the best for the last. And so it's such an inspiring presentation. And I do believe that the future of robotics is connected with the development of artificial intelligence and the imaging that is able to compensate the true limitations that we have with the platform. And only few experts and pioneers are able to use their personal skills to deal with it is. So I would like to finish because I think unfortunately we don't have much time for the debate, but asking each of you to give a very short answer about priorities. So in your opinion, if you would like to score the priorities for the future of robotic minimally invasive surgery in liver surgery, what is more important? The development of the true development of a new generation of imaging, like Jacques presented, or do you focus more on tools that we are lacking, or you are envisioning the overall platform, robotic platform could be different, less bulky, with different type of arms, and so I just would like to limit the choice at 3. If you could score, what do you think? Images, tools, or platform? And we can start with, in the same order, Human. What's your opinion?
I think it's 2 things. One is training the next generation. Okay, I actually think getting the next generation to use the technology and giving them access and giving them console time is number 1. Okay, and that's because I think that we now need to move away from all of us who are older, who are still stuck in the biases of the 20th century. But from visualization, I think a lot of the things that Professor Mariscal has shown is wonderful, and re-registration and all of that's wonderful. But I think the next step is really augmented reality for the bedside surgeon. Okay, and that's because we can now project 3D images from the console to augmented reality glasses and have the surgeon by bedside who is helping us see exactly what we see registered onto the patient. And so we presented a paper on that at the SAGES meeting this year. And I think that that is a very small step that will actually increase the efficiency in the operating room and use the technology we already have to go and augment our ability to do more advanced cases, coordinating the bedside surgeon with the console surgeon.
Thank you, Human. And John, what's your opinion?
Well, I think first of all, the first thing Human mentioned was not one of the choices, but I was thinking the same thing as Dr. Fong, that training really is critical. But I think imaging is, and as Dr. Mariscal presented, clearly for me, what I need at my level is the ability of incorporating imaging and preoperative planning and knowing where certain structures are especially in the liver or in pancreatic surgery, where vessels are and things like that before you get to them. I'm happy with the tools. I'm happy with the platform. I could be pretty much fine with those. So I'll go with option number 1, imaging.
Thank you.
Improved imaging.
Cian.
Even though I'm given the task to talk about instrumentation for parenchymal transection, but I think there are still a lot of instruments you can think of, how you can use it for transection, but I'm pretty satisfied at the moment, even with very simple ones. Caesar, harmonic scalpel will be good enough for most of the procedure. But I'm not saying you don't need to develop more instruments, because you just can't imagine and how surgeon would think about making use of different types of equipment to do the same type of operation. I mean, there will be diversity of opinion. But having said that, imaging is important. Imaging is definitely important, from preoperative 3D simulation to intraoperative augmented reality, and definitely would be the way to go. And once again, training would be another area. Having spent so many years in doing surgery, but still a kind of issue how, apart from you are able to do a good surgery, how you can pass on the skill to other generation. And this is the way how we can popularize robotic surgery. I think this is pretty important. And so having said that, 3 options, I think at the moment, I still choose the imaging. Imaging would be more useful for us to master the complex anatomy, what we can encounter in liver surgery most of the time.
Thank you, Cien. Pierre?
He's muted.
Pierre, I think you're muted.
Okay, sorry, do you hear me?
Yes.
Yeah, sorry. Yeah, so I think I'm consistent with the friends here, and I thank Jacques for his presentation. It's always impressive and like a great show for the future. Yes, I mean, the liver is a solid organ. Since the beginning, it was very difficult to know where we go. We started with the anatomy, the segments. So it's not very different that the open or robotic surgery. And I agree, even today, we need to do more before we do surgery. I think the group here, we're pretty sophisticated. We have tests, and it's rare that we find today things we do not expect during surgery, but it's still the case in many centers, etc., that they go and you don't know. So I think imaging and knowing what you do is for me, clearly the number one priority. And I really look forward that what Jacques has shown can become routine in our practice. I mean, the patient would benefit dramatically on this.
I think we all agree. And it's always a little unpleasant to have homogeneity. I think diversity is a richness, but here we are all in agreement that the future is connected with the next generation of sensors and in imaging intraoperative. I leave to Jacques because I think it's his topic as to say the final words, and then I will close the meeting.
Thank you very much. No, you know, if we want to invent the future, if we want to be crazy, really, personally, and all the team of engineers in IRCAD, and we have more than 50, they believe that one day, especially for hepatic surgery, one day surgery due to the robot will be automatic. We know semi-automatic, automatic. Not now, perhaps 30 years, 50 years, not the problem. That means that we need priority imaging, but we need also the connection between the image and the tool, intelligence tool due to artificial intelligence. And if we have this circle, virtuous circle, one day I'm convinced it will be possible. You imagine it's not tomorrow that the FDA will give the authorization to do that, because today we have not the authorization to implant a needle, but that is my vision. So score one, it is really virtual reality, augmented reality, but also in score two, tools and connection between both.
With this very perspective words of Jacques Marescot, I would like to close this fantastic webinar. I thank you all for the nice presentation and the comments. And I would like to invite you all and all the kind attendees and the participants of this meeting to our monthly appointments. And I think Human touched the question. I would like specifically to invite him to be part of this panel for the robotic training. Are we doing enough? Because it's very true. One other limiting factor for a wider adoption of this technology is the training. So I think with this final invitation, I would like to close here the meeting. Thank you to all, and enjoy the rest of the day or the night. Thank you.
Thank you very much.
Thank you.
Bye. Thanks.
Thank you, Pierre, for
Thank you
the,
so much.
thank you guys.